Welcome back to our after lunch session. I hope you're all able to stay awake and listen attentively to really what I think is a really exciting session, taking us from our launching pad of this morning and really offering an opportunity to dig into some of the insights that have already been generated. So I'm going to start off with an introduction to our speakers today, and then we'll say just a few comments about what to expect on this panel and some of the themes that we'll be engaging with here. So we have three fantastic speakers, and I especially love that they represent different perspectives on the design and implementation of AI technologies in healthcare environments. So first we'll have Alinani Simukanga, who is has the primary application developer for the project that he'll be telling us about today, Project Search, which is an acronym for Scanning Ears for Child Health. He has an MSc in computer science from the University of Zambia and currently is working at the University of Zambia as well. So we'll hear from Alinani first. After that, we'll hear from Neoshi Shah, who's a qualitative researcher and writer who works at Quicksand Design Studio in India. And she brings the perspective, I think, unique at this workshop, the perspective of a designer, human-centered design, which is, I think, something that requires a lot of attention as we think through the ways in which AI algorithms are being embedded into healthcare environments. So her work is especially focused on design for health and technologies. Then our final speaker is Kagiso Ndlovu, who's a senior lecturer in computer science at the University of Botswana and coordinator of the eHealth Research Unit. So he has a PhD and is a telemedicine digital health researcher, and he's also the chairperson of the Digital Health Technical Working Group under the Ministry of Health in Botswana. So very different kinds of experiences and perspectives that will be brought to this session, which is definitively about implementation. And the planning committee had quite a bit of discussion about the meaning of this session in contrast to the first session. And so much of research ethics and research dialogue about AI being introduced into healthcare environments surrounds the question of, does it work? Does it achieve the outcomes that we hope it will achieve? Is it effective? And in this session, we're taking a bit of a step back from that and asking a question that I really think is actually prior to that, which is about implementation. Is the technology being adopted and used as intended? Because we can only evaluate the effectiveness, the true effectiveness of an AI, an algorithm or a technology, if it's being deployed and used in a healthcare environment in the way that it is supposed to be or intended to be. So in this session, we're looking specifically at studies of issues related to implementation. And implementation presents some shared and some unique ethical issues from a research ethics perspective. So many of the themes you'll hear will be continuous with this morning, and I get the sense the conversations in breakout rooms will really sort of bleed together, which I think will be really constructive for what's to come out of this discussion. So implementation happens with particular communities in particular places, in particular healthcare systems, and in particular policy or government contexts. Those things all matter for how implementation happens. And we'll hear a bit about each of those through our presentations today. So these will raise a number of questions that we'll get to and we'll discuss in the breakout sessions immediately following. So with that said, I'm very happy to hand it over to Alinani. Thank you.
Okay, good afternoon, everyone. My name is Alinani Simukanga. I'm a computer scientist, as Jay mentioned, based at the University of Zambia, and I'm part of Project Search, where I'm the primary application developer. Project Search is a collaboration between Boston University and the University of Zambia. So the title of the case study is on the ethical issues associated with the development of an ear biometric tool for patient identification in Zambia. Sorry, trying to get the clicker to work.
The big green button with the forward arrow is not advancing the slide.
Okay.
Oh, there we go. Thank you.
Thank you. So I'd like to give you a brief background of our project before I dive into the ethical issues that we faced. So, a challenge that's not unique to Zambia in our continent, I think it's something that's common in other LMICs, is the issue of identification of patients, because Zambia, like other countries in the region, rely on paper records for record keeping. So this is a challenge that we are seeking to fix or solve through the use of ear biometrics. So one might ask why exactly we are picking on ears. Facial scans, of course, carry privacy concerns compared to ear scanning. Iris scanners are expensive and can also frighten children, because the primary focus of our work at this particular point is in developing a biometric tool specifically for use in infants. So I think that's a picture that's all too common in facilities in countries similar to Zambia. Registers similar to the one depicted in the image over there are what's used to keep a record of data. So as mentioned earlier, we are focusing primarily on infants, and child health visits currently are entirely paper-based. Some facilities are digital first, but that's more to do with ART visits primarily. So there's growing support from the Ministry of Health to support this digitization. So what we are doing is we have developed a biometric tool that's deployed on mobile devices that can be used to capture ear images. What follows is a feature extraction process that extracts these ear features and allows for a matching process to take place on device. This then presents the healthcare worker with a top 10 list, a ranked list of patients prior to the intervention process that follows. So following this, I'd like to dive into some of the two ethical issues I chose to highlight for this conference. The first one being that of fairness and equity. So one issue that we ran into early on in the project was the availability of ear images or basically dark-colored ear images. Because we intended to deploy this tool in Zambia, we needed to train our tool using a data set that more closely mirrored the target population. So initially, we, of course, did not have access to this, so we relied on a data set of images that was collected in Boston at the Museum of Science, which all went well and good, but upon initially testing it in the local context back in Zambia, we noticed a drop-off in performance. So of course, this meant that we needed to curate our own data set from Zambia and, basically proceed by using that to train our tool to correct some of the biases that were introduced into it from the initial data set. So consent forms were approved by both the Boston University IRB as well as the University of Zambia Biomedical Research Ethics Committee. Okay, so one thing to note, of course, with this first ethical issue was that if we had failed to notice this bias that we had introduced into our algorithm at this stage, this would have led us into a situation where we built a tool that does not solve the problem in our local context due to the training data set. So the second one is that of transparency and engagement. So even though we aren't at the implementation stage of a project, we still felt it necessary to conduct community engagement to basically figure out some of the things that might prove to be stumbling blocks later on in the project life cycle. So let me just go on to the next one. So with that in mind, we had included this in our grant application and made it known to our funders that we intended to do this. So funding was secured for the various activities. Of course, this included interviews and focus group discussions with the mothers of the infants, with healthcare workers at the facilities, with the information officer and district health director to sort of provide input into our study, to also let us know, as I mentioned, the challenges we might face and whether there would be some level of acceptability of us deploying such a tool, because you have to remember that, as mentioned, when it comes to infant health, most of our facilities is entirely paper-based. So there's obviously that technological gap that we need to cover. So some of the things that came out of these interviews and focus group discussions was that there was some fear of malicious intent from the mothers of the infants, and also just a general unwillingness to divert from the status quo, from the paper-based records. So, of course, further engagement is needed to overcome these social, cultural barriers. Okay. So in conclusion, of course, community sensitization is key in tackling the social cultural issues that might be a hindrance to the adoption of digital solutions, especially AI in this case. The fact that we are capturing biometric data, which is inherently invasive, in our case, capturing the ear images, it's invasive, so this also goes to further heighten fears amongst our people that they already have towards technology. So the task of conducting this engagement, of course, has to be shared between the local body, in our case, the Ministry of Health, and any researchers that are doing work in the AI space. Okay, of course, researchers also carry a burden, of course, because in our case, we are the experts in our field, so we need to make sure that any benefits that our tools bring are, we need to make that clear to people and encourage discussion at that level. So thank you very much.
So, hello, check. I think, here, I'll use this. Yeah,
okay.
Use it. Thank you. So I think we have at least 5 minutes for some questions. So did anyone have questions of clarification? I see one over here. Paul, thank you.
Thanks so much for that great presentation. So my question is actually based on ignorance. So my question is actually based on ignorance. So initially we heard that fingerprints are the in thing in terms of identifying individuals, right? And then we heard about the eyes, right? And now you are telling us about the ears. So what is next? So I'm actually trying to think, let's say if you look at someone in terms of reliability of this method of identifying individuals, what would happen if someone were to change their diet, right? Because I think you're actually relying on the shape of the ear, the contours and stuff. What would happen if someone were to change their diet and they start eating a fat, based diet? And particularly when I'm looking at our women in the region, they would put some headgear that actually would even go on top of the ear, even putting some pressure against the ear. Would that affect the reliability of this technology in terms of identifying individuals? Thank you.
Okay, thank you for that question. Okay, so I'll tackle it in two parts. The first one was basically how will the tool work when there are any changes in diet. And so this is something we've been looking into because, as mentioned, our focus was initially on infants. And one thing that we quickly found out when we had conducted an infant growth study, an ear growth study rather. So one thing we noticed is that between birth and 6 months, the velocity of ear growth is at its highest, and that presented the biggest challenge in identification. So, of course, it's definitely a challenge, but we're hoping that moving towards machine learning solutions, deep learning basically, if we can have a larger complement of data per participant, we are hoping that that will allow us to buy back any performance loss due to growth in the case of infants, or any changes in diet, or piercings, or any other changes that might be made to the ears of a patient. So that's definitely something that we noted early on, and it's something that we are working on. Yeah.
Okay, thank you. And another one. We'll go here, and then we'll have time for one more. Thank you.
Thanks. Do you have any idea how long during child development does this biometric tool will remain stable? And what happens with piercing? Is it altered?
So yes, piercings do alter. In fact, we saw a drop in performance after piercing. But one thing that's very common in Zambia is that most female infants receive their piercings very early on, actually. In most cases by the 6-week visit, because just to give you extra context, we were capturing our ear images as infants were coming in for vaccination visits. So in most cases by the 6-week visit, which is the first data capture, most female infants already had their piercings. So it's definitely a factor, but yeah, as mentioned in my answer to the previous question, we are hoping that by using a larger pool of data per participant, we are able to make up for any losses in accuracy due to that. Instead of relying on one data set, or one data point rather, we can have a larger complement to fall back on, so that our model can focus on other features of the ear rather than just looking at something that might only be appearing in 1 or 2 images.
Okay, thank you. Yep, we'll come over here.
Thank you for a nice presentation. You brought a very interesting perspective of a gender perspective. And I'm curious, how did you deal with the consent processes, and especially when the mother said that they wanted to talk to their husband?
Okay, so in our case, that was used as the inclusion and exclusion criteria, because, and anyway, I should note this at this moment. The study that we had done sometime last year, it was quite small scale. In total, we were only able to follow 224 infants. But at that point, our focus was more on creating a longitudinal data set, so following them from the 6-week visit to the 9-month visit. So our focus initially was just on seeing the effect of growth and how that then impacts our ability to match. So basically the model, how well it's able to correctly identify a patient. So in that case, whether or not the mother was willing to participate was then used as inclusion or exclusion criteria.
And we have time for one more question. I saw a couple of hands here. Yeah, we'll come here. If you could stand up, yeah, thank you.
Hi, I may not have got the point that you were saying regarding the community engagement, that people had concerns, you said fears towards technology. So I just wanted to know, did you understand where these fears were coming from? What were their past lived experiences? How did you address them? Did the study stop because of this? Did it get changed because of this? So basically along those lines.
Okay, thank you very much for that question. So most of these fears towards our tool were basically what they told us was it just came from this mistrust basically of technology. You know, like I'd mentioned, you know, most of the visits at that point, antenatal, prenatal, you know, currently are just entirely paper-based. So we're now moving from that to a situation where, you know, a healthcare worker is bringing out this device, a mobile phone with an attachment to it, and putting it up to the ear of the infant. You know, some mothers were skeptical of what we are doing and what we intended to use this data for. Of course, we tried our best to inform them of what we're doing, but of course, some people, you know, might just have this inherent mistrust of technology, and in some cases of, you know, people who aren't healthcare workers in the facility and moving around with a device they haven't seen before. Yeah.
Okay. Thank you for raising that really important point, and I suspect that will feature prominently in breakout group discussions. So, and join me in thanking Elinani for that great talk.
So this is good, right? Audible?
I think so.
Yeah. Okay, thank you everyone for this morning's session. It was wonderful. And I'll be talking about artificial intelligence for behavior change in health. And I'd just like to point out that this topic is slightly different from what we've been discussing so far, because it's not the use of machine learning for patient care, health, or information management, but it's an example of using artificial intelligence for health workers as employees of the system. So we all know that hand washing is extremely important in reducing hospital-acquired infections, but global studies show that health workers either aren't able to or don't wash their hands according to protocol as required. And the manual method for improving their habits, which involves supervision or training, can become very resource intensive. So we were trying to apply human-centered design to understand what are the best ways of deploying artificial intelligence for this task. So we worked with a technology partner. They had a system called Vajra Hands, which operates in two parts, where you have a display monitor on top of the wash basin, where the health worker can get a tick or a cross for every hand washing step that they may get right or wrong. On the left, you can see the screen, the display as they would have seen it when they are using it. And the data that's collected on the basin is aggregated, anonymized, and made available on a dashboard to the management so that they can see the performance at a ward level. You can't know the health worker's name or their identity through the dashboard. Now, this is just to give you a glance of the scope or the extent of our research. It was across 3 states in the country and 7 public facilities in India. Right. So I imagine that the process of human-centered design might be new for some people in the room, so I've just included a few slides to explain our work. It typically starts with foundational research where we would be visiting all our fields, all our project sites to understand a health worker's challenges towards hand washing and also their response to a new technology like AI. And we made sure to talk to staff members across the cadre because these can be highly hierarchical settings. Then our findings are typically synthesized and we come up with a few ideas to improve the adoption of technology and thereby their compliance to the hand washing protocol. There are multiple rounds of feedback where we take these ideas back to people on the ground and fine-tune them until we have a final set of interventions we want to work with. So this is a glimpse of the final interventions, which I will cover in greater detail when I talk about the ethical issues. But the first thing we did was to improve the user interface of the device itself. The bigger picture is the new interface, and the smaller one, the inset, is what it used to look like. I'll come to the details in a moment. And the technology improvement was supported by non-digital interventions as well, like training or providing video material on the importance of hand hygiene and so on. There was also a game that we developed on hand washing for the staff. And finally, we had an end evaluation of our work in multiple ways. We were, of course, getting data from Vajra Hands, which told us whether the actual hand washing is improving. We had surveys and in-depth interviews and focus group discussions, so it was a mix of qualitative and quantitative. Now I'll get to the ethical issues, and I think the picture is missing here, so I'll have to go back to a slide. But I'll explain the ethical issue first. So Vajra Hands was actually designed to evaluate people according to the World Health Organization's steps on hand washing. But at most of our sites, we found that the staff actually uses a local protocol for hand washing. And the second thing is that they found the screen very confusing. So as designers, we tried to simplify the screen. I'll just go back and now explain it. So on the right, what you see is almost like a video tutorial where the person just has to look at that graphic, conduct the step, and if they conduct it right, they get a tick at the bottom or a cross at the bottom. But in simplifying it this way, we felt that we had actually reduced the space for people to practice variation. So I'll just explain this. The algorithm, typically you can wash your hands like this, you can wash your hands like this, but for the algorithm to mark you right, you have to do it in a very specific way. So one of the questions we're asking is that if we use algorithms for behavior change, how do we tread the line between adherence and agency? So that's the first ethical issue. The second relates to soft coercion. So like I said, that we had a dashboard and we improved on the dashboard where we provided data visualization to the management so that they could very quickly understand how their staff is performing on hand washing. But in our end and this was extremely important for people on the ground because never before did they have numbers or any graphs and charts to understand a micro behavior like hand washing. But in our end evaluation, we found that some of this data was being used to scare the staff into performing better, where the management would tell them that the government is looking at you through the camera at the basin, so you better do your best. So we've been deeply concerned about soft coercion, like how do we protect health employees against this kind of fear, blame, and shame, as computer visioning and AI may be increasingly used in their workplace. And the last is what I've called number play. So one of our learnings was that typically health workers don't wash their hands according to the protocol because they don't have enough motivation. If you're firefighting constantly, it gets deprioritized. So we had introduced a short competition cycle of 6 weeks. But in the bargain, their focus completely shifted away from the behavior at hand. So we had instances where some of the sites would ask their senior staff to wash their hands more at the basin to get the numbers right, or they would curtail people's access to the basin, saying, you please don't use it because you don't know the WHO sequence, which lends us to ask a long-term question that as we increasingly use AI, how do we also invest efforts in helping people build a more honest relationship with data, but particularly performance data. And then coming to the last part of my presentation, am I good on time?
You're good.
Yeah. Yeah, so coming to the last part of my presentation, these ethical issues might look disparate, but you can actually find a soft interlink between them. What happens, at least in the Indian public health system, is that a lot of projects like ours get signed off by the state without a meaningful dialogue with the hospitals or facilities where the project is going to be implemented. And therefore, when you reach the ground and when you start work, you might have teething issues of the kind that I described earlier, where the protocol might not match what they do on the ground. And as the pressure builds up on the management or the middle rung of decision makers, they are more likely to use soft coercion and number play, or like just trying to get the numbers right so that they can meet your program outcomes. And therefore, in conclusion, what I'd like to say is that of course, it's absolutely imperative to have a social understanding of technology by the time it reaches the stage of implementation. Human-centered design, by its very name, suggests that the field has the mindset and the skills to bring more voices in and ensure better adoption or to iron out adoption challenges. But what we also find is that the current research regulation frameworks, I don't know how HCD fits into the current ethics process, that's one. And second, that regulatory bodies need to account for the political realities of the implementation countries. Like I mentioned, in India, there's sometimes a fracture between the state that signs off on projects and the hospitals where the projects are implemented. And finally, I'd like to say that we feel the need for some checks and balances against tech solutionism, where policymakers might be given an audit tool or a resource to understand the problems where AI might be most effective, like where should you introduce technology versus where you could continue with your current system or continue improving it. So that's just on my work.
Thank you so much, Neoshi. I think your presentation does such a great job at taking our attention away from the development of the algorithm and into the context in which it's being used, from the immediate clinical environment all the way to the issues of the institutions that govern them. So we have just over 5 minutes for questions of clarification. There are a few at the front here. Maybe we'll come up to the front here first. Thank you.
Thank you for the presentation. I think this basically brings back to the main point that we can't totally rely on the AI. It needs human support also.
Yes.
So maybe with the good supportive monitoring by the staff there, senior staff, it would make the difference. And what your project, what you have told, is it a continuous thing, or is it a time period or some project which you are seeing going to see the results?
So the study phase was, of course, contained. It was over 8 months, but the machines, we've left them at the hospital. So they continue to function there, and we provide a light touch support in terms of just maintenance. So if there's a hardware, software issue, they have someone they can contact. But the study component, where we were understanding their challenges, developing interventions for them, and then evaluating the impact of those interventions, that has ended.
Then I think it needs a buy-in by the people who are there in the hospital.
Yeah.
Okay, thank you.
Thank you.
That's great.
Thank you. You can just pass the microphone behind you. Yeah, perfect.
Hi, Neoshi. Thank you very much. My name is Mahesh. I, in fact, have 2 questions.
Okay.
Because I am a hospital administrator also, so from the administrator point of view, see, there is a Right to Information Act in India. So as long as it is in a development phase, it is exempted from disclosure, and because it's an IPR. But if a hospital buys this, right, and if deploys and it is a public health, if it is funded by the government, then if someone asks this information of these video clippings under the Right to Information Act, have you thought about it? Because many times people ask us non-patient identifiers or non-hospital employee identifiers, which we capture through our cameras. So that is one aspect one need to look into. So if you can respond to that, then I can ask you now.
Sure. So, Mahesh, honestly, I had not thought of this before your question, but I can answer that in two parts. If there is provision under the RTI Act, then the technology firm should be sharing the data if required. But this is a two-edged sword, because we know sometimes that the data can be used against the lowest staff categories. So because you come from the Indian context, maybe you will understand how non-medical contractualized labor can actually be further oppressed if you release videos of their hand washing. So I'm not sure about the ethics of, even if we are obliged to share them, whether that raw data should be made available. And second, I'd just like to point out, which might make for a great discussion point, is that none of the hospitals where we worked did we get any questions of this kind. So the data literacy sometimes is so low that they've not started thinking about what happens to the raw data that Vajrahans is collecting. I can explain it further if it's of interest, and I don't know if that directly answers your question.
No, that's fine, because it is still, we need to find answers. And my second question is actually related to it. Because see, right now also hospitals collect data through active passive surveillance for hospital infection control, right? You mentioned about soft coercion. There is another aspect to it. If the patient starts suing the hospitals because of the high infection rate and because of the deaths, and now if there is such evidence available through videos which one can get through the RTI Act, and then say, here is the evidence that the hospital's hand hygiene compliance is low, leading to high infection rates, and then the deaths of the patients, so I'm suing the hospital. So there are legal issues might arise related to that. That is, I just wanted to, if you have any thoughts on that.
Right. So first I'd like to clarify that I may have misunderstood your first question. When you said under the RTI Act, did you mean that the patients would ask for the videos, or did you mean the
Anyone can ask.
Okay, anyone.
Any Indian citizen can ask information under the
RTI. So again, we have not considered a legal scenario like that because we're not even sure if the patients that access the public health system would use a legal tool like the RTI and get into hygiene and infection prevention measures. But what we are thinking, so we've got an extension for this project, and what we are thinking of is actually using this data as an advocacy tool. So if actually the hospital can make a case for how they're not able to follow protocols because of staff shortages and severe time crisis, this data could in fact help them advocate for better resources and infrastructure. So we've considered alternative uses of poor compliance data, but not from the perspective of the patients asking for videos.
Yeah, this is a wonderful tool. So just I wanted that there can be cons as well for this.
Yeah, there can
Thank
be.
you.
Yes, thank you.
I think we'll have to end there. Please hold on to your questions for the breakout groups after, and join me in thanking you.
Thank you.
Oh, yeah, okay. All right, so first of all, thanks to the organizers for inviting me to come and share what we've been doing in Botswana. So my topic is around ethical considerations while using a clinical decision support system called Bioethics in Botswana. So this project was a collaboration between the University of Botswana, and Bioethics, a US-based company, and then of course funded by the Bill and Melinda Gates Foundation. So I'd like to start my introduction by saying the health sector globally is undergoing transformation, particularly in low and middle-income countries, towards addressing issues around rising cost of healthcare and also mitigate shortage of specialists. In Botswana, specifically, we have inadequate health human resource in primary healthcare settings. We have a low doctor-to-patient ratio, as you can see in that there, a shortage of medical specialists, particularly within dermatology. And we have 2 full-time dermatologists under the Ministry of Health, and then of course 3 on contract from Cuba. Average waiting times would be around 6 months or more for patients with complex dermatologic conditions. So there's few dermatologists that are there, they are prone or they incur fatigue, cognitive and cultural biases. And bringing a technology balancer could actually reduce, if not eliminate, the effects of such biases. So AI, as already highlighted in the morning, is a promising field in the health sector. The private sector, particularly within developed countries, is actually leading these innovations. Universities, like the University of Botswana, where I come from, an opportune platform for testing such solutions, proof of concept, capacity development of skills or knowledge exchange, and also sustainable uptake of AI. So these are sort of technologies that sort of mimic or simulate human intelligence. We've been told about machine learning, deep learning, I won't go into that. But what I want to emphasize is quality data is very essential for AI applications. So perhaps that is the starting point for adoption in LMICs. Do you have that quality data? Some of the benefits: automation of tasks requiring human interventions, addressing critical shortages and skilled personnel, as I said previously, improved access to services in remote areas, empowerment of the healthcare professionals, so they would benefit or they would get upskilled as they interact with such solutions. More value out of the available data. You can imagine data just sitting without using it for anything, so AI brings a promise to get value out of that data. I like pointing out that machines can never replace human physicians. So they're just there as tools. They're just there to augment or support us in our decision making. After all, a human being is not a set of computable data. There's some element, or there are some things that a physician can pick that a machine cannot pick. For example, if a patient is moving the left arm more than the right one, or they're showing some emotion on the face, or even basic things as engaging with their relatives about how the patient is doing. So that requires a human intervention. So we collaborated with VisualDX, like I said. So it's a US-based company with over 20 years experience. This is a company that was formed by dermatologists, health informaticians, computer scientists, and programmers, with over 70 staff capacity, and their mission is to improve healthcare decision-making worldwide. The platform was trained with over 80 million images, dark and light skin type of images. So the collaboration was research, so it was a research project. The project aimed, or rather sought to assess feasibility of a mobile clinical decision support system in Botswana. Two aims: we wanted to check the feasibility of VisualDX usage in patient care settings in Botswana, and also gather feedback from the users as to what could inform its improvement so that it could better serve our patient population. We had to undergo research approval. We had to seek for permits, starting with the internal IRB within the university, and then we had to also seek permission from the Ministry of Health. So the current IRB, permit is still underway up to 2023. So VisualDX, in short, relies on image analysis. So the model uses convolutional neural network. So it's a deep learning algorithm that seeks to mimic human vision, so how you perceive and analyze and interpret images. So you take a picture of the skin lesion, as you can see on the far left there, and then the algorithm would analyze that using those 8 million images that were used to train it. And then it's not prescriptive, so it would rather ask you the third step to confirm the diagnosis. So as I said from the beginning, machines will never replace you, but they're just there to guide you in your decision making. And then furthermore, it would give you a platform also, or rather an interface to select the part of the body, whether somebody is male or female, and then end with a review of the diagnosis possibilities. In terms of ethical considerations, informed consent, very, very important. After IRB approvals, so study participants, they had to consent to participate. And then beyond that, consent was also given to engage further as new knowledge was discovered on the disease. Because the platform also has got some tons and tons of resources that we could query about a particular condition if probably what we saw didn't really make sense, so you can further interrogate it. So you can also ask the participant, or we rather ask participants whether they would like to continue being informed about new findings from the platform. In terms of safety and transparency, the platform uses peer-reviewed and expert-validated content, most of which are from dermatologists, or dermatologists actually validated the content. Is GDPR and HIPAA compliant, which speaks to privacy, confidentiality, and security. We had continuous sensitization to upskill the users, most of which were healthcare or nurses rather, so that they could safely use the solution. It is non-prescriptive, so it gives you options so that you also engage with it. And then also we had teams, so that there is second opinion if need be. And then transparency, I want to say transparency is one of those hot topics nowadays, transparency of algorithms. How transparent can an algorithm be? And what data needs to be made transparent to the public, and what doesn't need to be made publicly known? So like I said from the beginning, these are private companies after competition, there's business associated with what they are doing. So there is also corporate secrecy that comes into play. But at least with our this platform, VisualDX, shared with us, as you can see that graph there just shows the DEM expert feature, which is the AI model. In terms of its accuracies over time. So this information that we shared with the users so they know how accurate the model is. In terms of the fairness and bias or discrimination, so it's a dedicated deep learning model where we've been trained by over 80 million images, as I alluded to earlier. An aspect of trying to eliminate the bias, so there had to be a lot of images from both dark and light-skinned, type of images. Federated learning, this is one technique that is normally used in AI to sort of desist from relying on one initial data set that was used to train the model, but rather have secondary data in another setting, help further train the model. So somewhat, even though it was not the primary objective of the study, VisualDX also learned, from the data that was gathered, gathered in Botswana, those images that were collected in Botswana. So the model is not prescriptive, like I said, so that's another aspect there. Privacy, adherence to data protection standards, I think this HIPAA and GDPR. Images were not stored on the device, so we are using mobile devices, most of which were tablets and smartphones. The app is available on both Android and iOS, so the images, they are just available on the interface for the clinician to interpret and analyze and view the possible diagnosis, after which they are discarded. So that's another privacy issue that was inbuilt within the solution. So discarding of those images after analysis, and then collection of de-identified and generalized demographic information about patients. So that was another. In conclusion, VisualDX was well received despite infrastructure issues, connectivity issues, and so on and so forth. And I must also indicate that the solution is currently under consideration by the Ministry of Health to be embedded within our national EMR as a decision support tool, considering that we've got very few dermatologists in country. Health systems also are unique, so some of those technologies, they may not fit across different care processes. So as they vary, private sector, they've got a way of doing things versus public sector, and also within the public sector, things are done differently. Quality data is a big issue and a significant barrier. Our government is still, grappling with the regulatory role, of establishing good machine learning practices oversight of how this algorithm should behave in real life scenarios. And then, of course, methods, effective methods of rooting out bias while adhering to ethical practices. I mean, these are serious concerns. Regulating algorithms, big challenge. These algorithms, they evolve very quickly. So you regulate one, the next day there's an improvement or enhancement of that algorithm, so it becomes a tedious task. Thank you so much. That's the end of my presentation.
We have time for a couple of questions. Are there questions of clarification for Kikiso? Yeah, we'll come to the back. Thanks.
Thank you for the presentation. I have a very simple question. You're introducing this technology because of the shortage of experts, dermatological experts, and therefore you're using this technology to address that shortage. Now, the technology you're introducing is not prescriptive. So at the end, it does not identify whatever you're suffering from. So in the end, you're going to need an expert to interpret or diagnose. So doesn't it come back to, I'm wondering how it ends up solving the issue of shortage in terms of medical experts?
No, thank you so much for that wonderful question. So the way we're implementing this, we had teams. So somebody within a dermatology clinic, if there is a nurse, there should be some doctor who is a part of the team, and also some dermatology who was an expert, even though there were few. And then there were some also that were outside the country that were also a part of the project. So they were working as a team. So the platform, like you are saying, I mean, you are rightfully saying, is not prescriptive. It doesn't really say, okay, this is the one diagnosis. So it gives you 3 possible diagnoses. So as somebody who has been working in the field, you should also be able to, tell, this is something that is close to what, or you should be having rather something in mind before you see what the tool could, put forward as a possible diagnosis or as a solution. But overall, these people working in teams, and then of course assessing the feasibility and the reliability of that decision support system within the environment.
Okay, thank you. I saw there was one, Adrian, you were going to somebody here, and then we can come up to the front here.
Hello, can you hear me? All right. One of the things that we regularly, as a developer, encounter is that the regulatory body is not ready to answer our question. They do not know how to regulate us, even though we want to do good machine learning, but they do not know how, how do you as a developer goes to that? Are you telling the regulatory what kind of things that they have to do, or you cooperate with them? Or what's your role helping the regulatory body to better regulate us as a developer? Get what I mean?
Yeah. Okay, I'm not sure whether I got the question clearly, but do you mind just repeating that again?
As a developer, we want to develop machine learning tools, right?
Oh, yeah, yes.
And then when we ask the regulatory body, the government, or sometimes do not know do not know how to answer our question because they don't have the they don't know how to, it's a new thing, so they do not know how to regulate us. So in that position, do you work with the everybody to create a framework, or do you just sit and wait for the regulatory to come up with the framework?
Yeah, I think it's a very, very important question. I think what he's pointing is the mismatch between software developers and the regulators. So the regulators would sort of push back solutions, so they would not probably give permission to developers to develop certain tools. I think this calls for capacity development within the regulators. There has to be capacity so that they could understand how these technologies, how they work. In order for them to better regulate, you should have an appreciation and understanding of how the technology work. And of course the most important is the protection of the subjects. Be able to tell this intervention will not compromise the privacy, the confidentiality of the data, and also the security. So I think it boils down to having right people or right skill sets or knowledge or know-how within the policy makers or decision makers, so that when these innovations are presented to them, they don't come as something that is not feasible or it's a huge risk, but rather the opportunities to enhance the way things are being done, or like improve quality and also performance in how things are being done. Yeah.
Okay, thank you. Now we'll transition to general discussion, which we can have until 2:55. So we're just under 20 minutes. So Kagiso,
okay.
Let's thank Kagiso for his talk. So we have opportunity now for questions, comments in relation to any of our speakers' presentations today. So yeah, we'll start at the back and then we'll come up here to you immediately after.
Yeah, so my first question is in relation to the last presentation. In terms of feedback, we were looking at patient feedback. I'm looking at the point which you raised, which is about getting feedback from the physicians themselves. So how much are they internalizing that this is assistive or supportive and not something that will replace them? That's one part of my question. The second is maybe across the panel, that's looking at the long term. Who owns this tool? Once the research phase is over, this tool, whether it is hand washing or whether it is this detection tool, when it goes into the hands of the commercial developer, then who has access to it? What are those costs involved? And who will fall between the cracks?
Thank you. So Kagiso, why don't you respond about the feedback from patients' perspective, and then also on the second question about what happens next.
Okay. Yeah, thanks so much for those wonderful questions. So the first question was around the feedback, from the health workers who are evaluating. I think what we're interested in was whether this is feasible. Does it fit within their workflows? Does it help them to make decisions quicker without having to refer patients to the few specialists? So how we went about that, we were using technology acceptance model, which has 3 constructs. So we're assessing usability of the platform as acceptance and also overall, I think the other one, so usability, acceptance, I'm trying to recall the third construct here, of TAM. Yeah, so usability, acceptance, I'm forgetting the third one. So there are 3 constructs under TAM model. So yeah, so we had some questions that we administered, to them so that they could rate the app, based on those, 3 constructs of, TAM model. And overall, they were actually happy that the platform was usable, that it was fitting within, it was, perfect within their workflows, and also it gave them what they thought, they needed. It empowered them. They were even happy to use it even beyond, clinical hours. So the feedback overall was positive. And then in terms of who owns the solution, in our context, this is a solution that was owned by VisualDX. So it was just used in Botswana to, as a pilot. So all the intellectual property rights, everything is with the private entity. But then, of course, ministry had to give us permission to, pilot the platform within the facilities, and also patients had to consent to be a part of that. So the sole owner was the developer of the solution, being VisualDX.
Thank you. Just Elinani or Nyoshi, do you want to comment on that? Yeah, why don't you go ahead? If you're just in terms of ownership, collaboration with the private entity, building an AI technology, ownership after the initiative, so on.
So in our case too, the ownership lies with the technology firm who's from the private sector. The devices or the hardware per se has been gifted to the facilities. So that continues to be with them. And unfortunately, I mean, I don't know what else to say, because currently even these public-private partnerships in India are happening under a policy vacuum, right? We don't have any law or regulation. Even the bill that was going to be passed in the parliament was revoked. So we are perhaps a unique country where we don't have any data protection laws or regulations around this kind of public-private partnership. So I don't even know, what the rights of the facility would be in holding a private organization accountable in the future in case there are breaches. I'm sorry, that is the limitation on my part, but if...
Yeah, Alinani?
So, unfortunately, in my case as well, it would end up in private hands, not because we don't want to let go of it, but mainly due to, the nature of the setup in the local context. The EHR that's used in public institutions is currently managed and maintained by a private firm. So even after we develop our tool that sort of plugs into this EHR, we would have to pass it on and leave it in the hands of this private company. So unfortunately, try as we might, it definitely won't end up under public hands just due to the lack of capacity to manage it.
Okay, thank you. Sure, quickly, Nyoshi, yeah.
Sure. This was as a clarification to Mahesh's previous question. Mahesh, when you asked about who can access the videos, I just wanted to mention that the videos only capture people's hands. At no point do they capture their face or identity. And the last thing I just wanted to emphasize was that this case study might be differing from the other two at the table, in the sense that the technology firm is a local one, it's not from the global north. So, in case the geopolitics.
I think we've folded in a number of issues, sort of observations around this particular point, which I'm sure will be a popular topic of discussion in the breakout groups, and I think it really should be. So I think let's move on from that point for now. I promised a question up here, so Adrian, we'll come up here next, and then we'll move on. Yeah, right here in the front. Thank you. And then
one of them has already been answered, but it produced another question. So I'll just ask all of them. The first presenter, you mentioned that you get samples of like 8 million. I wanted to find out if it's from your country or it's from the world. And in case if it's from other places, how do you determine that it is also relevant to your setting? And then for you saying the data is being owned by the private developers, I'm just wondering how did the protocol get approved if there was no social value to coming back to the community? Because that's one of the key things that has to be considered before something like that, even if it's going to help people in general in the world, one of the key things to consider is that it has to come back to the community and be able to also be accessible to the community who are participating in the study.
Okay, sorry if I answer it. Could you just repeat the first part of your question? I didn't catch that clearly.
The first part of the question is, you had mentioned that when people are being diagnosed, you have I don't know if it's a database or repository of images that you already have, that whatever picture is taken, it's being, or maybe I'm confusing. Oh, I'm confusing, sorry.
No, I can answer.
Oh, you've, okay. Thank you, sorry.
I can hand it off. Okay, so maybe I should clarify. When it comes to our project, it's really the tool that would end up in private hands. When it comes to the data, due to data privacy laws that are in place currently in Zambia, especially in reference to health data, patient data, this is held by the state in data centers that are under the control. So the data itself isn't what would end up in private hands. This is currently, as things stand, being held by the public, by the state. It's a tool that would end up in that particular example I gave. That's what would end up in private hands. So I hope that's enough of adequate enough of a clarification.
Okay, thank you, yeah.
All right, yeah, so in terms of the images, the 80 million plus images, you're saying where are they? So these are in the company that owns the platform, which is Bioethics, so they're in the US. Remember, the images were just used to train the model. So once the model is trained, then the app could be tested anyway. And then, of course, those were dark-skinned and light-skinned images that were used in the US, so they would remain there. In Botswana, the model was just being tested to see if it can, read those images or analyze them and give us something that's meaningful, or that dermatologists would actually validate, say, yeah, indeed this is okay. Because the objective was to validate or sort of feasibility of that, platform. Maybe also just to take advantage of it, I think the third construct we were looking at that I forgot earlier was ease of use. So is the platform usable? Is it acceptable? Is it easy to use? So those were the three constructs that we're interested in terms of the feedback, pointing to the earlier question. I remember that.
Okay, no, that's good, thank you. We'll come to the question here, yeah?
Okay, merci. Sorry for the French, I'm from a French country. I have a question for the last presenter. Sorry, sir, you talk about the color, the skin color in your country. Maybe I'm wrong, but I think as other African country in Botswana, you have dark and light skin color, but you use your device only on dark skin color. Why?
Okay, I hope I got the question correct. So we used on dark skin color. So if that's what we mean, we are testing this on any skin color or any patient presenting with any skin color in Botswana, seeing if, we have predominantly dark skin color in Botswana, or skin, dark, skin pigments in Botswana. But that doesn't mean we don't have people with a light skin color in Botswana. So the model was tested across all of them. So we are not saying, okay, we want to test it on dark skin. So I thought maybe just to put emphasis there, we have a majority dark skin, but any patient who would present, regardless of their skin color, we had to, if they consent, would see if the model would, better diagnose or not.
Thank you. Adrian, yeah, do you want to just go ahead? Thank you.
Thank you very much. And mine is to Alinani. In your very important experience with a biometric ear, did you manage to come up with any specific recommendations you'd give to the ministry to enable them to construct a framework for public engagement with AI in general? Did you manage to come up with any specific recommendations from your experience? Thank you.
Thank you for that question. So unfortunately, no. I think as mentioned in our paper, most of our engagement that was conducted only went as far as the district level. I think the highest we're able to climb up the totem pole was the district health director. So hopefully, one could hope that, with if we continue to see more health AI research in our local context, that this will hopefully drive this, or at least accelerate this process and get this discussion occurring high up the ranks. Thank you.
Thank you. And an important point as a suggestion for development. So I think that's great. And Adrian, another question at the back there.
Hi, I have a question for Nayoshi regarding the hand washing experiment. I wanted to know that was there a thought for cost-benefit analysis or some kind of a post-facto impact assessment of that project? Because using AI intervention for a micro-behavior, just wanted to understand what were the logistics like. Thank you.
So we did not have a component of like cost assessment. I know that's a whole special field in its own. So we didn't evaluate our project according to the cost effectiveness. But in terms of funding or how it works, I could shed some light on that if it's useful.
Yeah, no, my question was more that we are using an intervention like AI for managing a micro-behavior.
Yes.
So was there a thought or an impact assessment to see that whether intervention for such a micro-behavior, the kind of cost and the benefit side, was it commensurate with that? Or maybe a human level monitoring could have been sufficient for such a case? Just trying to understand that aspect.
Right. So it was not built into our project study,
Okay.
but we relied on literature review, which explains how, not following, so hand hygiene or hand washing falls under what we call infection prevention and control measures. And not following infection prevention and control measures, or when the compliance rates are low, the likelihood of hospital-acquired infection and mortality is higher. Even without AI, this can be very tricky to quantify, because very often you might have a patient who contracts an infection after they've left the hospital, right? So tracking them throughout has not been easy, which is why we have relied on existing literature to just understand what is the potential benefit of improving compliance rates. And we also, now that we have this tool, we're also trying to gather data, like a baseline data. So what we do is, when we set up the machine in the hospital, we cover the screen. So they can't see the video tutorial that I explained, which helps us understand what are people's hand washing behaviors before you start the machine. So it's not just an assumption that the compliance rates are low. We get a fairer idea of where their compliance starts, and therefore whether AI is helping or not. But the latter part of the story of whether improving if you improve hand hygiene, how much of your infection levels drop, is not built into our study, just given how difficult it would be to measure two research questions.
All right, thank you.
Yeah.
Okay, thank you. So we won't take any more questions now in plenary, but I just have to apologize to Adrienne, because she asked me to mention the hashtag and Twitter before this session, and I think that's just my subconscious feelings about Twitter right now. But the hashtag is GFBR, so if you are tweeting or still tweeting, then please engage with that hashtag.